I welcome Dr. Gomati Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shenai, Program Coordinator. And today the topic is Ovary and Uterine Pathology. And our coordinator is Dr. Tara Pradap, Head of the Department, VPS Lakeshore Hospital, Kochi. I welcome Dr. Tara. And our faculty is Dr. Anu Sara Isho. She is in charge of Women's Imaging and Fetal Radiology, Malankara Orthodox Syrian Church Medical College, Kolanjeri, Ernakulam. I heartily welcome Dr. Anu Sara Isho. And now over to Dr. Tara for the introduction of the speaker.
So good evening to all. I welcome all of you to this session on PG case presentation conducted by the academic wing of Kerala IRIA. And the faculty for today's session is Dr. Anu Sara Isho, who is in charge of Women's Imaging and Fetal Medicine at MOSC Medical College, Kolanjeri. So she is a fellow of Royal College of Radiologists, and she has had her training from JIPMER Pondicherry, and then she had a FRCR, and she's been a speaker at various national and state conferences. And now we have two PGs with us, Dr. Nanya and Dr. Elizabeth, and there will also be a spotter session towards the end of the presentation. Now I welcome Dr. Anu for the proceedings.
Thank you, Dr. Tara, for the introduction. And I also want to thank you and Gomati ma'am and Renu sir and Ramesh sir for inviting me for this session. And without delay, we'll start. So we have 4 cases, and I'll share the screen and then the PGs can start presenting. So this is a 50-year-old lady who came with a mass in the abdomen. She felt that there's abdominal protrusion, and then she underwent an ultrasound scan and then further evaluated with MRI. So I'm sharing the MRI images. So PGs can see. I'll scroll from here, and
okay, ma'am.
You can see and you can describe the findings.
Okay. Ma'am, I'll start describing, or
yeah, you can say.
I'm given MRI axial images, T1 weighted images. It shows a large multi-septated lesion with solid component noted within. In the cystic part of the lesion, part of the cystic part appears to be iso to hypointense, while part of the cystic lesion, part of the cyst appears to be hyperintense on T1 weighted images. There also appears to be a solid components in the form of intramural projections, papillary projections, mural nodules, and large solid areas. I'm also given T2 weighted images of the same patient. And in the T2 weighted images, the cystic component which was appearing T1 on hyperindence is appearing T2 hyperindence as well. The rest of the cystic part also appears to be T2 hyperindence. The solid area appears to be heterogeneous in T2 weighted images.
I'll give you the diffusion weighted.
There is no evidence of any diffusion restriction noted.
So part of the lesion shows increased signal intensity on diffusion.
Diffusion. Okay.
Yes. So we'll go on to the dynamic images. These are the dynamic images acquired after giving IV contrast.
Okay. The solid part of the lesion appears to be enhancing, and the enhancement appears to be almost equal to the enhancement of the myometrium when compared to the myometrium.
Anything else you're seeing? Any other finding? Any lymph nodes or
There
in the
is
visualized session? Are you seeing any enhancement of the peritoneum or any deposits? We can see. You can say otherwise.
no, ma'am. No obvious peritoneal deposits are seen, ma'am.
As you said, the lesion is showing, the solid part of the lesion is showing enhancement, and comparing it with the myometrium, some part of the lesion is definitely showing more enhancement than the myometrium.
Okay.
But I'm not able to retrieve the dynamic curves from the of this patient, but we can compare with the myometrium and see. So how will you compare with the myometrium? What is the
the 30 to 40 second scan, we compare with the myometrium. If the enhancement is less than the myometrium, we classify it as ORADS 4. And if it's more than the myometrium, we classify it as ORADS 5.
Yes. So this dynamic enhancement helps us to characterize the lesion. Okay. So from the MRI, what do you think is a component of the lesion?
As there are T1 and T2 hyperintense images, cystic parts in the lesion, the possibility of I've not given fat saturated images, so the possibility of a fatty component of the lesion as well as hemorrhage should be considered, ma'am.
I'll give you the fat sat images. These are the fat sat.
In fat sat images, there is attenuation noted, hypointensity noted. So the part appears to be fat density. That part appears to be fat density.
So the part of the lesion where it was hyperintense on T1 and T2 is suppressed on fat sat images.
Fat.
So what that means?
It is
part of the lesion contains fat.
Okay.
Can it be hemorrhage? This part, can it be hemorrhage?
It is suppressed on fat images.
So it is a fat containing part of the lesion is fat containing.
Fat containing.
So what are the other things which will be hyperintense on T1? If you see something bright on T1, what all will you think of?
T1 hyperintensity can be due to hemorrhage, proteinaceous material, mucinous material, or fat. So in hemorrhagic, it can either be a hemorrhagic cyst or even endometrioid can be T1 hyperintense. Mucinous cystadenoma can be T1 hyperintense.
So this is a very useful sequence, this fat suppression sequence. So it helps us to confirm the fat content of the lesion, but only part of the lesion shows fat.
Okay.
Okay, and we are not seeing any nodes in this visualized part of the abdomen.
Okay.
And rest of the abdomen also, liver was normal, and there were no deposits in the liver.
Okay.
So from this, what are your differential diagnosis, and what is your, how will you categorize the lesion? According to ORADS, how will you categorize it?
So it's a solid, there is a solid enhancing component in the lesion, and this enhancement is seen to be more than the myometrium. So I'll consider it to be an ORADS 5 lesion. But there is some fat within the lesion seen. So the possibility of an immature teratoma or a mature cystic teratoma undergoing malignant transformation can be considered, ma'am.
Yes, as you said, that will be our first differential. Will be a immature cystic teratoma, because mature cystic teratoma you won't see so much solid enhancing areas.
Okay.
Sometimes Rokitansky nodule can enhance mildly, but large nodular enhancement or papillary projections are not seen in mature cystic teratoma.
Okay.
So this is an ORADS 5 lesion. We'll move on to the discussion. Okay.
Okay.
So this histopath came as a surprise because the diagnosis from the pathologist was a collision tumor. That is, there were two histologically distinct tumors were there. One was partly it was a teratoma and partly there was serous carcinoma. So it was histopathologically reported as a collision tumor, and it was located. It was limited to the ovary. There was no spread into the peritoneum. These are the CT images. Actually, the patient initially came for CT. So we had acquired few CT images, then we did the MRI. So just to show you, this is the fat containing part of the lesion where the attenuation is -143. Okay. So as you said, ORADS helps us to categorize the lesion and tell the clinician on how to manage the lesion further. So depending on whether the lesion is, depending on the nature of enhancement of the lesion on a time intensity curve helps us to say whether it is a category 3, 4, or 5. Now 3 will have a lesser enhancement. It will be a low risk curve, and 4 and 5 will be higher risk for malignancy. 5 will have more enhancement than the myometrium. So, so this lesion was categorized under, as you said, ORADS 5. Okay. Now, ORADS 4 will have an intermediate risk, and here the lesion will have still lesser enhancement than the myometrium, but there will be it will be an intermediate risk curve, and there will be solid nodular enhancement in the lesion. Okay.
Okay.
So as you said, the other T1 hyperintense lesions can be a hemorrhage, which can be in the early subacute phase. The hemorrhage, or in the late subacute phase, it can appear hyperintense on T1 and T2. So it can mimic a fat-containing lesion. This is the signal intensity curve for a high, intermediate risk, and low risk. See, in the high risk, the early part of enhancement, it is more than the myometrium. Okay. Can you see my slides?
Can see the slides, but you're not changing the slides. And what you can see is the one with case discussion. We are not able to see the other slides.
Okay.
Yeah, they are not actually changing. The slides are not changing.
Can change to slideshow mode.
Where is that option?
You can go either. Yeah. Yeah.
Now can
Yeah.
you see?
Yeah. Now, yeah. Again, it went. Put the slide share mode.
Is it okay now?
No, no, no. Go up, Anu. Can you go up? You can see animation design slideshow in the left-hand side top. home, insert, design, animation, slideshow. Go up. Yeah. Click the slideshow or resume slideshow. Yeah. Now it's okay. No. 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 Put slideshow.
Lower one, right? Oh, it's okay.
You just, no, it's not coming. You just change. I think some problem is there. You can just go to the other slide. Go to the next slide.
I'm going to the next slide. Probably it's not changing for you.
Yeah, it's not changing. Yeah, click it. Go to slideshow. It's not coming, no?
Not coming.
You go to next slide.
I am clicking on, and in my screen, the slide is changing.
Yeah, here it's not changing. Soumya, can you help her? Soumya, are you online?
Yes, I think what she can do is she can click on the slide show mode and can start from the beginning.
Beginning. Yeah, that will be better.
Now it's changing, right?
Yes.
Now it's changing, but it's not in slideshow.
Yeah. Now it's okay. But when I'm
It's
going to
okay, no problem.
slideshow, it is not changing.
No worries, no worries. You can.
You can continue like this, Anu. Continue
Yeah.
like this.
Yeah. Okay, so these are the CT images where we can see the fat containing lesion, and as I told you, the dynamic imaging helps us to to categorize the lesion further into ORAD's category 3 or 4 or 5. And ORAD's category 4 will have a high risk, intermediate risk curve, and the enhancement will be lesser than the myometric. But in our case, the enhancement was more, a part of the lesion showed more enhancement. So we categorize that as 5. And late subacute hematoma can mimic a fat containing lesion and can appear hyperintense on T1 and T2 weighted images. Okay. So our fat suppressed images helps us in that. And this is the signal intensity curve where we can see that the high risk lesions will show an initial enhancement which is more than that of the myometric. So what all are the T1 hyperintense lesions in the ovary? Elizabeth, can you tell me? What all are the T1 hyperintense lesions?
T1 fat containing lesions, lesions which contain hemorrhagic lesions and proteinaceous lesions, or mucin containing lesions.
And sometimes rarely struma ovary or now as in our case, dermoid cyst or it's a fat containing lesion. So all these will appear hyperintense on T1.
T1.
So hemorrhagic cyst, this is a picture of a hemorrhagic cyst on fat suppressed images. It won't, the signal won't be suppressed, and that's how you differentiate. This is a endometriotic cyst. Okay.
Okay.
Now, even sometimes the mucinous tumors can appear with high protein content, can appear hyperintense on T1. For that, we can, as I said before, using the multiple sequences, we can differentiate between the lesions. Even struma ovary can appear hyperintense on T1, and mature and immature teratomas can appear hyperintense. So final diagnosis is a ORADS category 5 lesion, as you said, and the patho report was a surprise. It came as a collision tumor. Okay, so we'll go on to the next case. Any other faculty have any questions, or is it towards the end, Dr. Tara?
Towards the end.
So this is the next case. This is a multigravida. She came for the ultrasound scan in the 3rd trimester. For routine checkup she came, and on the ultrasound, the placenta was appearing a bit more bulky, and there was a doubt whether the placentation was abnormal. And so to further evaluate, we have done an MRI. I'll show you the images. You can start. See.
The images provided to me is a short echo view pelvis view of a T2 weighted images of pelvis. It shows a low-lying placenta with the fetus in the cephalic positioning. The placenta appears to be low-lying and appears to be lying just superior and anterior to the urinary bladder. The placenta appears to be superior part of the placenta appears to be extending along the anterior abdominal wall. The margins of the placenta appears to be irregular. However, the hypointense area of the margination between the placenta and the bladder appears to be maintained here in the image given to me. In the
Any other findings?
The presently scrolling images is of a T2 weighted axial images of the same pelvis of the same patient, which shows multiple flow voids within the placental region. Otherwise,
So okay, so here we have a the placenta is appearing mildly thickened. It's low lying, as you said, and here we are not able to see the hypointense uterine wall clearly.
stream is not very well defined here.
Not well defined. So, but contrast imaging was not done because the patient had concerns of contrast going transplacentally to the fetus, and we had to stop with the plain images. And from the plain images, we gave a diagnosis of what is your diagnosis?
Since the myometrium towards the inferior aspect is not very well defined, I would think about abdominal placentation, like placenta percreta.
Yes, so the placentation is abnormal, and definitely there is a placenta percreta, and even the margin with the bladder is appearing ill-defined. There are multiple flow voids, multiple dark T2 dark hypointense bands within the placenta.
Yes.
So all these are pointing towards the diagnosis of a placenta percreta.
Okay.
We can see some of these findings on an ultrasound image, like a loss of retroplacental lucency or extension of the myometrium into the placenta, etc.
Okay.
To clearly see the extent into the adjacent organs, it is much better to do a MRI.
MR.
So she was planned for LSCS and even an option of uterine artery embolization was given to her, which she refused. And finally, LSCS was done. So this is actually the specimen, because finally she had to undergo a hysterectomy along with the LSCS because the placenta was extending outside the uterus, and however they could dissect the placenta completely from the bladder. There was no invasion into the bladder, but it landed up in a hysterectomy. So this is a case of placenta percreta. So what all are the types of abnormal placentation? Nimia?
Other than normal, three types of abnormal placentation are accreta, percreta, and increta. Accreta is one just touching the myometrium, while invagination into the myometrium but not breaching the serosa is the increta. If it is breaching beyond the serosa, it is called as the percreta.
And what all are the risk factors?
Risk factors like multiple previous cesarean sections, then previous surgery to uterus, then previous abortion which has ended up in DNC, like uterine curettage and all. Then previous low-lying placentations because of low oxygen tension in the lower uterine segments, like placenta previa and all. Previous history of placenta, like abnormal placentation is also itself a risk factor.
Okay, and the complication will be life-threatening hemorrhage. If it's not diagnosed in the antenatal period, it can lead to heavy bleed during the
delivery.
The time of delivery. Yeah.
Yes.
So this is the ultrasound image of the patient, and here we can see that the placenta in this image also it's extending outside the uterus and it's extending on the serosal margin.
Okay.
So that is the so it's relatively easier to diagnose a placenta percreta, but the lower forms of placenta accreta and increta a little bit difficult to diagnose on ultrasound. So you have to have a high index of suspicion. If there are risk factors, you should see carefully whether these are the described findings on the ultrasound in cases of abnormal placentation. That is, you won't see a retroplacental clear space, which normally separates the placenta and the myometrium. And if it extends beyond the myometrium, it can even interrupt the echogenic line between the bladder and the myometrium. And the myometrial thickness can be less than 1 millimeter. So all these things you can is useful for in cases of high clinical suspicion where you think the patient has high risk of developing abnormal placentation. And what are the MRI findings? This is our case where we can see that the most useful sign described as the outward bulging of the placenta, which is seen here, and irregular placental myometrial interface and thick, dark intraplacental bands. So as you described previously, there were multiple flow voids, prominent vessels, and there were dark septae within the placenta. And role of intervention is in uterine artery embolization. Balloon is used for occluding the uterine artery. Dr. Nimia, can you tell me how it is done? When it is done?
During the multimodality approach of during the time of cesarean section, then intervention can be done by balloon catheterization of the bilateral internal iliac arteries, so as to get a bloodless field likewise. Then in case of any bleeding which is not feasible for it's becoming life threatening, then intravascular embolization can even be tried.
Yes. So these are representative images. It's not our case, and here is how it works when embolization is done for abnormal uterine perfusion. Here before embolization and after embolization. So we'll move on to the next case.
Can you please show the ultrasound image once again? This is for Dr.
Yeah.
Ajay. So he has said that he was not able to see the ultrasound image.
Sure, I'll show you. Can you see? Here there is increased vascularity in the placenta, and actually you're not seeing a myometrium at all. This is a bladder, and this vascular structures are extending up to the bladder wall. Next case is a 61-year-old lady who came with abdominal pain, and MRI was done, and I'll share the MRI images. Can you see?
Yes, ma'am.
So intravaginal gel was administered, which we typically do in all our cases. This is it. Sorry, that's a bladder. Sorry, this is the vaginal gel. This is the bladder.
Ma'am, shall I start describing?
Yeah, you can describe.
So I'm given T2 coronal images of the patient, of the pelvis of the patient. In this T2 coronal images, I can see here predominantly T2 hypo-intense solid lesion noted in the left adnexa. Axial images are also provided. The left ovary is not separately visualized from the lesion. So it is a T2 hypo-intense solid lesion. In T1 weighted images, the lesion appears to be iso to hypo-intense to the adjacent muscle. So it is a solid lesion which is T2 and T1 hypo-intense. On diffusion weighted imaging, there is no hyperintensity noted. It is a T2 dark and diffusion dark solid lesion.
These are dynamic images.
Okay, ma'am. On contrast weighted imaging, the lesion shows a mild enhancement. However, it is significantly less than the adjacent myometrium. So from the given MR images, we have a T2 dark, a diffusion dark, solid lesion. So ORADS 2.
Why do you say ORADS 2? What are the other things which you look for? Are you seeing any lymph nodes, or are you seeing any free fluid in the imaging section, images that you have been provided?
No, ma'am. If there are peritoneal deposits or lymph nodes, the ORADS category changes, ma'am.
So this is a well-marginated lesion in the left head neck, sir. Okay. And one thing which you missed was the right side also there is a small lesion. Okay.
Okay.
This is small, similar lesion with similar characteristics in the right ovary also.
Okay. Okay.
So we are not seeing any peritoneal deposits or free fluid, no signs of definite signs of malignancy is not there. So it's a solid lesion, but it is T2 hypointense and diffusion weighted hypointense. So we can categorize this. That will come to in the next slide. So this is a solid tumor, and the histopath was Brenner's tumor on the right, in the right ovary, and fibroma in the left ovary. It was reported like that, and it had benign features. There was no nodal involvement. There was no peritoneal deposits. Everything was clear. And so we'll discuss about solid ovarian tumors. Solid tumors can be benign or malignant. Benign, what are the benign solid tumors, Elspeth?
Fibromas, thecomas, fibrothecomas, Brenner tumors.
These are benign tumors, and solid lesions can also be malignant if it's very irregular, if it shows very high risk type of enhancement. If there are nodal deposits or peritoneal deposits, we should think of a malignant solid lesion. So by ORADS, we can categorize the lesion, so that will help the clinician more in treatment and management of the patient. So according to ORADS, any lesion which is dark on T2 and diffusion weighted imaging and which is solid can be categorized as ORADS 2. It can have mild enhancement, but still if it's dark on T2 and diffusion weighted, it can be categorized as ORADS 2. And what all are the T2 dark ovarian lesions? Solid lesions.
Fibromas, thecomas, fibrothecomas.
Okay. The other T2 dark lesion in the ovary can be a endometriotic cyst with shading.
Shading, T2 shading.
Shading can be there. But these are the solid benign lesions of fibromas and fibrothecomas. So they will be, they can be categorized as category 2. So this will be the pattern seen on a MRI in case of fibroma and fibrothecoma. That is, it will be T2 dark diffusion dark, isointense to mildly hypointense on T1, and mild enhancement on post-contrast images. So all this fits into a case. This is the ultrasound image of the same patient. Actually, in ultrasound, it was more suspicious of a broad ligament fibroid. And due to the inadequate window, we could not really rule out whether ovary is there near the lesion, whether it's actually a broad ligament fibroid. So with MRI, it was clearly arising from the ovary, and we could nail a diagnosis of ORADS category 2 lesion. So ORADS 4 and 5 will be high risk, which we have already discussed, that will have a high risk enhancement on in MRI in dynamic post-contrast images, while ultrasound ORADS also you can use to categorize the lesion. What we already discussed is the MRI ORADS, right?
Okay.
So ultrasound also can be used, and in ultrasound, if the lesion is solid with smooth outer contour and any size with a color score of 1. Color score 1 means there is not much vascularity. So if the color score is 1 and if it's very smooth, if it's a solid lesion, you can still put it in ORADS category 3 on ultrasound. So by ultrasound, this lesion was ORADS category 3. This is the ultrasound ORADS 4 and 5. Our case did not fit into any of this. Okay. So we'll go on to the next case. This case is quite an interesting case, because this lady came to us with acute abdominal pain, and this is a 31-year-old lady. She was mentally challenged, and she could not give any proper clinical history. Can you see?
Yes, ma'am.
These are CT images of that 31-year-old lady with acute abdominal pain.
CT axial section of a 31-year. Shall I start, ma'am?
Yeah.
CT axial sections of a 31-year-old female whose history is unknown shows a heterodense area noted in the right iliac fossa and the pelvis in the right side. It appears to be a well-defined lesion with irregular margins, and multiple hypodense areas are noted within. A few linear hyperdense areas are seen within the area. Significant surrounding fat stranding is seen. The aforementioned lesion appears to be a cystic lesion with enhancing walls and enhancing septation. There is another. I think it is a U. Okay. Ma'am, can you? Okay. Another midline structure, probably the uterus, appears to have a central hypodense area, which appears to be hypoenhancing, while the periphery of the area appears to be enhancing. The left adnexal region also appears to be bulky, with multiple hypodense areas noted within that. Significant surrounding fat stranding is same, and minimal fluid is also seen adjacent to this area.
Anything else?
Appendix is visualized and it appears to be normal in caliber with multiple luminal air pockets are seen within. So might be normal.
What are
The
your
other visual.
differentials? Any other positive finding?
Bilateral adnexal lesion, bilateral ovaries appears to be bulky with significant surrounding fat stranding, and in view of the acute presentation and significant inflammatory changes surrounding this, and there appears to be multiple enlarged engorged vessels are in the region also seen. So in view of an acute presentation, my first differential will be a tubo-ovarian pathology, tubo-ovarian abscess like pathology. Then, since it is involving the right iliac fossa and the appendix is not fully, so I will also put a differential of an appendicular mass also. But here, both the ovaries appears to be bulky, both the adnexal appears to be bulky. So I will keep the first differential as a tubo-ovarian pathology only, ma'am.
Okay, as you said, there is a right adnexal mass, and you said correctly that it is predominantly a cystic lesion. And these cystic, with peripheral enhancement, and these cysts are intercommunicating. And if you elongate and see, it's actually tubular intercommunicating structure.
Okay, ma'am.
So what can it be?
It can be fallopian, like hydrosalpinx is a possibility. So it can be pyosalpinx is a possibility since there is a significant inflammatory changes surrounding that area.
So significant inflammation is seen. The adjacent bowel loops appears to be adherent to the lesion. And any other finding?
Then uterus appears also to be bulky with central fluid density is seen. So in adjacent pyosalpinx is the same. Pyometra or hydrometra can be also be associated.
Anything more you want to comment about the uterus?
Ma'am, cervix is not visual.
Yeah, as you said, we are seeing a uterus-like structure, superior and posterior to the upper part of bladder.
Yes, ma'am.
But below that, we are not seeing any uterine uterus-appearing structure, or we're not seeing any cervix-like structure. So that is also very confusing. It was confusing at that time, and then, but the appearance of this was almost like a uterus. So
Okay.
we did think about uterine anomaly because she was unmarried, and but she didn't give much history about her cycles or anything. But probable uterine anomaly, a Mullerian anomaly, was also raised after a CT, and with hematobar hydrosalpinx and hematobar hydrometra. And that was the final diagnosis which we gave. So we'll go on to the discussion of this case. So this case was immediately surgery was done because she had very bad abdominal pain, and as we pointed out in CT, there was a Mullerian anomaly, and the vagina was blind ending. The cervix was not seen. Part of the uterus, probably a rudimentary horn, was seen. Part of that is this structure which we can see here, and and also that rudimentary horn was filled with hemorrhagic fluid. with blood. Okay, and there was this hematosalpinx, and this had formed the tubo-ovarian mass. And on the left side also there was a rudimentary horn, but that cavity was not filled with blood. So she had a Mullerian anomaly with one horn having some endometrium within that, and that was there was some menstruation happening, and so in that there is blindating vagina also. So all this hemorrhage accumulated in the bleed accumulated in the fallopian tube and in the rudimentary horn, causing inflammation, and it was a chronic hematoma with a tubo-ovarian mass. So what are the types of the Mullerian anomalies? We won't go into much details, but our case can be classified as this U5 category, where there can be a rudimentary horn with some endometrial cavity. And septate and bicornuate uterus are also part of this Mullerian duct anomalies. We won't go into details due to lack of time. So this was a very interesting case, because initially we never thought of Mullerian duct anomaly, and she presented with acute abdominal pain, and so we should the other differential was probably a tubo-ovarian mass or an abscess, but there was not much enhancement, vertical enhancement in that area, in the lesion. So all the 4 cases are over. Dr. Tara, you want to ask some questions, or should we go to spotters? Or is there time for spotters? Should we wind up? Or?
No, I think we
can go for spotters.
We can go for spotters.
Okay. Please do tell me when I have to wind up, because I have some few spotters are there. Can you see the screen? Is the screen visible?
Yes, ma'am. Not as a full screen, but as slides.
So Elizabeth, can you say the diagnosis? It's a spotter.
Anencephaly, ma'am.
Yes, it's a, very easy one. It's an anencephaly. You can see that there is no calvarium. All the spotters are predominantly fetal imaging. It's an anencephaly. Dr. Nimia?
Yes, ma'am.
What are you seeing?
Kidneys appearing bulky.
Yeah, both the kidneys appear bulky and hyperechoic, and it was abnormal looking, and there was CMD was completely altered. There's a fetus of gestation age around 20 weeks. Okay, so it's a case of ARPKD. Okay. Dr. Elizabeth, what is happening here?
Hydrocephalus.
Yeah, the lateral ventricles are prominent, right? And here we can see that the posterior fossa, it's very narrow, and the cerebellum is not seen clearly. There is also some abnormal shape of the skull. can you see there is a, I'm saying because we don't have much time, I just say this. There is a spina bifida, open spina bifida is there. So what has happened is a KRE2 malformation. There's a spina bifida with cerebellar herniation. So this small posterior fossa and hydrocephalus. The next case, Elizabeth. What is any abnormality here?
There is an abnormal vessel training.
Yeah. We can see that this there is something hyperechoic here, and which is pushing the heart to the other side. And yeah, good. So what all are the hyperechoic? Can you name 2 hyperechoic lesions in the lung? In a fetal. Yeah, CPAM and sequestration both can appear hyperechoic, and how we differentiate is you have to look for an abnormal vessel going from the aorta to the lesion, and if the vessel is there, then it's a sequestration. So Nimia, what has happened here?
Dilated ventricle systems, unilateral ventricular hemorrhage.
So what is special about this? Is it just a hydrocephalus, or is there any peculiarity?
It is appearing unilateral.
That is because of the imaging section. It's bilateral actually, and the frontal horns are not dilated. What is this called? Colpocephaly.
Colpocephaly. Corpus callosum agenesis.
Yeah. If you see this, we should look for corpus callosum agenesis, and also there will be absent septum pellucidum in such cases. So here, usually in a mid-sag view, you will be able to see a hypoechoic structure, the corpus callosum. Here we're not seeing that. So it's a case of corpus callosum agenesis. Yeah. I'll just help you. What is happening here?
Herniation of post.
Yeah. The skull is appearing abnormal, and there is some hernia happening here. There is an encephalocele happening. Okay. Because of that, the brain is pulled out, and there is some hydrocephalus. And also there is a flat face. So some syndrome with encephalocele, because encephalocele, it can be a KRE3 malformation. Okay. Any guess? I'll help you in this. So here the heart is on this side, right? But we are seeing the aortic arch on the other side. So it's a right-sided aortic arch. And what is happening here is
VSD.
Yeah, there is a VSD, and also there is overriding of aorta, and we are not seeing the pulmonary artery at all. So it's a case of tetralogy of Fallot. What are the components of tetralogy of Fallot?
Overriding of aorta, VSD,
right-sided aortic arch, pulmonary atresia. So all the components are there. It's a case of tetralogy of Fallot. This baby was delivered, and they had to undergo surgery. Okay. I'll help you with this. What is happening here in this fetal spine?
Bifid.
So the skin is intact, but there is some hyperechoic lesion within the spinal canal in the lower region of the coccyx. Okay, and on detailed scanning, we could see that the cord was also tethered to that region. So something which is hyperechoic can be fat. So so it's a intraspinal lipoma with tethered cord. It's a closed spinal dystrophism. The baby was delivered, and later was on follow-up. Any guesses? There are two great vessels seen.
TGA.
Yeah,
TGA.
which is parallel. So it is, if you see something like this, we should immediately suspect TGA. And we can here also, but just with the two parallel vessels, we should not say it's TGA. We should do a detailed scan and see whether the pulmonary arteries are rising from the, here we can see that the pulmonary arteries are rising from the left and the aorta from the right. And there is also, if you can look carefully, there is also VSD. Okay. It's a case of transposition of great arteries. So here, this is the diaphragm. What is happening here? This is the heart.
Diaphragmatic
Yeah, it's a diaphragmatic hernia, and the stomach has gone up. So what I have measured here is the normal lung. Okay, normal lung, and that is how you measure a calculate a lung to head ratio. LHR has to be calculated because that will help in the management. The LHR is greater than 1.4. The prognosis is better. So we have to measure the normal lung at this in the region of 4-chamber heart, and also divide it with the head circumference, and that will give you the ratio. So that will help in the management, when to follow up, and for which fetuses the prognosis is better, we can predict. This is easy. You can you tell?
No.
There is a cyst in the posterior
portion.
What can
I
it
don't
be?
hearing.
Dandy walker.
Walker.
It's a dandy walker with bilateral hydrocephalus. This is, I mean, difficult to see, but I just want to show this is actually the hand is like this, and it's a club hand. It's called club hand, and the radius was now also absent. So it's a radial ray abnormality with club hand. The importance of looking for, diagnosing that and counseling the patient is because it can be associated with many syndromes, one of which is Fanconi's anemia. So they have to be told about the possibility of associated syndromes, which we cannot rule out antenatally. Can you make out? It's quite difficult to see, but the hand, no, it's not the normal orientation of the hand. Here, this is in this fetus, the FL was less than 1 percentile, and also multiple ossification centers were seen at 20 weeks in the region of head of femur. So possibility of contour dysplasia was raised because FL was very less, and compared to the other BPD and abdominal circumference, and they opted for termination, and this is the X-ray of the fetus. And here also we can see multiple ossification centers in the region of the head of the femur. So contour dysplasia punctator can be due to many causes, and further workup has to be done, like karyotyping and also genetic studies to see which genetic abnormality is there. So what is this? This is a cystic structure in the posterior fossa with a keyhole-like appearance. But the posterior fossa in general, the size of the posterior fossa is normal. This angle, the Vermian angle, is also normal. It is not, the vermis is not lifted above. So it's a tiny cyst is there in the posterior fossa, which is communicating with the fourth ventricle. So this is a case of Blake's pouch cyst. Importance is that on a follow-up, usually this resolves. Sometimes it can enlarge and cause hydrocephalus, which has to be explained to the patient, but generally this resolves, and on follow-up scan, you might not see it. This is Nimia?
CPAP.
Yeah. Hyperechoic lesion
Hyperechoic
in the lung. So it's a CPAM, and in this, what we calculate is the CVR. CVR ratio has to be calculated.
Okay.
And if the CVR ratio is more than 1.6, or if the CPAM is having a dominant large cyst, there is increased risk of developing hydrops. How you calculate the CVR is you have to measure the CPAM. The abnormal part is measured, and it is divided with the head circumference to get the CVR ratio. Okay. This is actually this is a 3-vessel trachea view, but we can see that there is an extra structure here. And what is it? It's a persistent left superior vena cava. The importance of diagnosing or looking for this is this can be associated with coarctation of aorta. So when you see this in during 20-week scan, you have to document it and do a serial scan to rule out whether there is any coarctation developing in the aorta. This is abnormal vessel, which this is the 3-vessel trachea view, and this is the trachea. The small black thing is the trachea, and normally you won't see a vessel like this. So this vessel is going from the aortic arch, going behind the trachea and going to the right side. So this is an aberrant right subclavian artery, and the importance of that is it can be associated with aneuploidies. So we have to do a risk assessment and see whether, and also see whether all the other aneuploidy markers are there, and then counsel the patient. This is a prominent umbilical vein. It's also known as umbilical venous varix. If it's more than 9 mm, or if it's fetal intra-abdominal part of the umbilical vein, if it's more than 9 mm, or if it's more than the intrahepatic part of the umbilical vein, it is called as varix, umbilical vein varix. The importance of documenting this is that sometimes it can enlarge, cause hydrops in the fetus. So we have to document it in our report and ask for follow-up scans to see whether it's enlarging, whether there is any edema developing or any cardiac failure developing in the fetus. So that ends our spotters also. Dr. Tara, any questions or anything else?
For the pages today, and it began with the collision tumor, and you should expect a collision tumor when there is more than one type of neoplasm in the same lesion. And as Dr. Anu has shown, like, the commonest combination is with the dermoid, and what we saw is a case of dermoid with the serocystic neoplasm. So that is a commonest combination. And then Dr. Anu had shown us a case of percreta. I think the diagnosis is rather easy on MRI, but the challenge is finding it out, the adherent placenta, in the early stages on ultrasound. And we also saw a case of fibroma thecoma complex with MRT2 dark appearance. And I think the last case was on Mullerian anomaly, and which can be asked as a classification of Mullerian anomaly. I think is one of the questions, theory questions as well. And we also saw a good collection of obstetric cases. I think there are no questions in the chat box.
No questions, and it was a wonderful session, because usually we just see all those ovarian tumors, all this. This was different cases which was presented very beautifully by Dr. Anu, and the residents also answered very well. All the spotters, they could answer very well, and congratulate Dr. Elizabeth and Nimya for their presentation. Thank you, Dr. Anu, for the wonderful cases.
Thank you, ma'am. Thank you for inviting me.
Dr. Venu, like, do you have any?
Yeah, nothing. All are good cases, and also the rare cases now.
Yeah.
Actually, I am seeing the placenta percreta for the first time. I haven't seen that ever.
Yeah.
So thank you, Dr. Anu.
Thank you.
Shall we wind up the session?
Yeah, we can wind up.
So I thank everyone who is from the organizing committee who made this possible. So I thank the PGs. I thank the MedPiper team for their excellent technical support. And I take this opportunity to thank everyone who has attended this session. And my special thanks to Dr. Anu for her conductive sections. The cases were excellent. So I think we are closing the session for today. And I would ask everyone to attend the session on July 1st, that is our talk would be on fetal medicine, and Dr. Meenu would be the speaker, and she would be discussing about imaging in IUGR. So thank you and good night.